Hello and welcome to Sleep Review's webinar, CPAP Masks. You never get a second chance to make a first impression. I'm Sri Roy, editor of Sleep Review, and I'm here with three esteemed speakers, Matthew Uhles, Lisa Bond, and Russell Rosensky. After the three presentations, we will answer as many questions as we can live. So throughout today's webinar, submit your CPAP mask-related questions via the Q&A box on your screen. Also, the complete slide deck is available for PDF download via the slide, download, and links box on the right-hand side of your screen. The webinar is sponsored by Fisher & Paykel Healthcare, Philips Respironics, and ResMed. For those interested in the AAST credit, the CEC is available for the live webinar only, which only applies to you if you are watching Monday, October 30th at about 9 a.m. Pacific time. Today's webinar is being recorded, but the pre-recorded version isn't eligible. On the webinar registration page, you must also have said yes when asked about wanting the credit, which was the default. For privacy reasons, we will not be submitting the full roster of attendees to the AAST, only those who requested the credit. So today, you must watch all three presentations and complete the exit survey that is on the left-hand side of your screen. Even if you don't want the credit, we'd appreciate it if you take the survey. Once you take the survey, the form will simply close. You won't get an immediate confirmation, but if you don't get the certificate needed for AAST confirmation by December 1st, email me at sroy@medcore.com. Let's start today's webinar with an audience poll. Please select from the choices on your screen. What is your current mask refit percent? So that is the percent of patients who switch masks soon after starting CPAP. There's a scale on your screen ranging from 0% to more than 15%. Make sure to click the Submit button so that we include your response in the calculations. I'll give everyone just another second to select their current refit percent. Okay, let's take a look at the results. And it looks like 5% to 10% is the most common refit percent of our audience today. And then the next most common is 10% to 15%. And about 20% of you say that more than 15% of your patients wind up switching masks pretty quickly after they are originally fitted. That gives us a good feel for today's audience, and no matter your current refit percent, we think today's webinar will give you several journal articles that will give you food for thought, as well as many practical tips and tricks. It is now my pleasure to introduce Matthew L. Uhles, MS RPSGT. As Chief Operating Officer of Clayton Sleep Institute, he manages its business aspects, including its sleep clinics, research center, insomnia programs, and educational outreach. He has more than 27 years of clinical and business experience in sleep medicine. He consults on the business and technology of sleep clinics with clients throughout the country. Welcome, Mr. Uhles. We're ready to hear your insights.
Thank you, and thank you to Sleep Review for putting this together, as well as inviting me to speak. So why is it important to get the mask right the first time? You know, studies have definitely showed that early CPAP usage is a predictor of long-term adherence. We know that within the first week or two, if a patient is using CPAP, they'll continue to use CPAP. If they're not using it within that first couple of weeks, they're going to struggle to pick up CPAP and continue to use this. The study published here shows as little as 3 days can predict adherence at 30 days. The effectiveness of the mask is important. If the mask isn't working, if it's not going to treat the sleep apnea, it's not going to take care of the problem long term. And if we don't get the mask right the first time, there's going to be costs involved. Those costs may include things such as the staff time, having to go back and refit the mask and spend time with the patient, patient travel time, and all of that, as well as the cost of the mask. CPAP masks aren't cheap, and a lot of the accrediting agencies have changed some of those rules and policies in terms of how many times a mask can be disinfected, reused. A lot of the labs and operations have gone to a single use. So if you try one mask on a patient and the patient doesn't like that mask, you have to try a different mask. That's going to incur a cost of 2 masks for the setup. And this is even included if you have the right mask, but the mask is the wrong size and you have to resize the patient. that's going to increase the cost of the mask. And then, of course, if the mask doesn't fit, if it's not comfortable for the patient, it's going to lead to patient frustration, and that's going to decrease the adherence of the patient, which may impact your collection and reimbursement on the back end. And if the mask doesn't seal well, if the mask doesn't hold up and it has to be replaced before the patient's insurance may allow them to have a new mask, that's going to increase costs to the patient or cost to the lab or DME. So what makes up a good quality mask? I'm going to leave this as two basic features and functions. The first is, does the mask actually work? Is it effective? And one of the things that's going to make that mask effective is, does it seal? Does it make a good tight seal? The second feature is, does it direct the air where it's supposed to? Basically, is it going to lower the sleep disordered breathing and allow the patient to be adequately treated? Doesn't matter how good a mask is, if a patient doesn't wear that mask, it doesn't matter. So in order to have a mask to be successful, not only does it have to be effective at reducing sleep apnea, but the patient has to wear it on a nightly basis all night long. Factors that are going to play into that are, is it comfortable? Does the patient feel it's comfortable? Are they able to tolerate it and wear it throughout the night? And is it easy for the patient to use? If it's comfortable but cumbersome and the patient has difficulty cleaning it, putting it on, understanding how to adjust a mask, they're going to be less likely to use that. Some of the problems associated with wearing CPAP masks, again, if it's uncomfortable for the patient isn't going to wear it. Some masks may rub the patient's nose or face, causing irritations or even abrasions. Some of our patients are allergic to the materials that go into the CPAP mask, and so allergies can be a factor. Sometimes the CPAP masks or interfaces can lead to congestion and decrease adherence with the patients. And again, going back to leaks, if the interface leaks, it can cause irritation to the patient, especially if it leaks around the eyes. It can cause problems with eye irritation. And as you all know, CPAP is prescribed by a set pressure. And so if we have a reduction in the amount of pressure due to the mask leaking, is going to reduce the optimal pressure and may deliver a suboptimal therapy. A lot of our patients are claustrophobic, and design and the style of mask and the headgear can play a big factor in that. Edmonds in 2015 reported that as much as 63% of the patients that they examined had a significant degree of claustrophobia. Weaver and Grunstein in 2008 published information that said that some of the challenges to effective treatment with wearing CPAP on a regular basis was if the patient perceived the mask to increase claustrophobia, if they thought the headgear was unattractive, and if the straps were too complex to use. Al-Jazmi in 2016 did a study looking specifically at claustrophobia and CPAP usage. They reported that the more comfortable a mask was, the more likely the patients were to use it, that the comfort actually determines the usage, and that if the mask was uncomfortable, they'd be less likely to use it and less frequently. They had a scale where they looked at if the mask was perceived as being restrictive or caused suffocation, and what they reported was that if the mask was perceived as having a higher suffocation and restriction score, that the patient's adherence was much lower than if the scores were lower. Some of you have been in the field for a while, might recognize this mask. If we go back, 25, 30 years ago, the number of masks that we had available to us only were 2 or 3. And over the last 30 years, we've had a wide range of improvements in terms of the types of materials, the designs of the mask, and ranging from the bias flow. If we go way back, we had separate release valves, and they were bulky and cumbersome. And over that 30 years, if we look at the improvements, I'm just continue to be baffled and amazed the amount of effort and resources to go into designing just a simple new interface. There are teams of engineers and researchers that work for years to bring one of these masks to the market. Yet, if we look at adherence from 30 years ago when we only had a couple of masks, to today when we have a plethora of different maps and materials to choose from, the published adherence rates are roughly about the same, ranging from about 40 to 60% of the average CPAP patient actually using their CPAP on a nightly basis. I think this underscores the importance of education and experience, the education and experience of the clinician, the physician working with the patient, the technologist running the sleep study, and then the therapist setting up the patient with CPAP mask. And this all comes at a time when healthcare is putting increased pressure on us to decrease the amount of time we spend with patients. As you all know, with home sleep testing, we're much less likely to spend that quality time with patients, fitting them up and titrating CPAP and adjusting masks throughout the night, but we have a much more limited experience and time range with them. Looking at the literature, is there any evidence that individual mask matters? Most of the published studies looking at CPAP masks and their influence really look at the class of CPAP and not particular makes and models of CPAP. So they compare classes like a nasal mask versus a pillows mask or an oral nasal mask, or even a couple of studies looking at oral-only masks versus the individual make and model of a mask. One of the better studies looking at this was published in 2014. It was a literature search they pulled about 91 different articles. Of those 91 articles that looked at CPAP, mask, and obstructive sleep apnea, there was about 12 that reported on the impact of the individual CPAP mask on adherence or on effectiveness. And there was 2 studies, I believe, that crossed over and included both adherence and effectiveness. These 12 studies that specifically looked at the impact of mask on adherence and effectiveness did not show a significant difference between a nasal-style mask or a pillow-style mask. They did, however, report that an oral nasal mask was perceived or demonstrated to be less effective and even impacting adherence and increasing the apnea-hypopnea index. A couple of studies reported that this may be due to increased resistance in the oral pharyngeal due to the oral nasal mask, and that the oral nasal mask was associated with significantly higher CPAP pressures in order to effectively lower the AHI. So you really only get one chance to make a first impression. Study published in 2014 or 2016 by Balcour took a look at their patient database over a 14-month period. What they did was they examined the number of patients on CPAP who switched CPAP masks during this 14-month period. So in other words, if we get the CPAP mask right the first time, will it have an impact on adherence and patient perception, or can we really have a second chance to make that first impression? They had about 2,700, a little over 2,700 patients within their database. Of that, 267 of those patients switched CPAPs during the first 14 months, or switched interfaces during the 14 months. Of the 2,768 patients, 566 of those were new setups. And of those new setups, 108 reported switching CPAP masks or interfaces within that 14-month period. So 19% of new CPAP users during this 14-month period switched out masks. If we looked at only the existing CPAP users, that number was much better. It was about 7.2. Looking specifically at what were the reasons for switching and what was the success rate once they switched masks, the largest category or reason for switching CPAP masks was a poor fit, or the mask was uncomfortable. 39% of the patients reported switching due to those reasons, and those patients who switched masks, 62% had an improvement in their adherence and CPAP use. 30% of the patients who switched masks were due to a leak related, and 50% of those were salvaged. The best salvageable group was for an outdated mask. So this was existing CPAP users who had a mask that they had been using for a while and were offered to try out a new CPAP mask, and 80% of those went with a newer mask. And the least successful category, and the smallest, was due to nasal congestion or stuffiness. 6% of them 6% of the patients switching interfaces were due to the nasal stuffiness, and 35% of those were salvaged. So total, 61% of the patients who switched an interface during this 14-month period reported an improvement. 76% of first-time users, or 76% of the individuals who switched from one mask to a second mask showed improvement, and 36% of those who actually used multiple masks. So they didn't like the first mask, they switched to a second mask, and even to a third or a fourth mask. Only 36% of them reported an improvement in CPAP at that point in time. Female patients were reported as more likely to switch out masks than the male patients. And the most interesting thing about this study was that individuals who switched CPAP masks were 7.2 times more likely to abandon CPAP during the course of it than patients who did not switch their CPAP masks. Now, following up with this, I had a follow-up conversation with our therapists here on staff, and here at Clayton Sleep, we are fortunate to not only do diagnostic testing, but we're also a DME and set up our patients on CPAP. So I asked our therapists about their refit rates, and what they reported was if a patient had an in-lab titration, we have a refit rate of under about 5%, very similar to some of the polling that we just took. If we look at an APAP titration following a home sleep apnea test, and the number of patients who request a new mask following those titrations, that number, depending on our therapist, is anywhere from about 10 to 30%, so significantly higher. The interesting thing was we have a couple of our physicians who talk with the patients in the office, and they have their own favorite mask, and they direct the patient to a particular type and style of mask that they feel is the best mask for the patient. And of those patients, regardless of whether it's in-lab titration or an APAP titration, only about 5% of them reported requesting a refit. Here at Clayton Sleep, we do have a policy in which we allow patients to switch out their mask within the first 30 days. We request that they keep the mask that they start off with. We give them a second mask. And what we find out is about half the time, they'll go with their initial mask over the second mask. And we do require them to use CPAP for a minimum of 14 days before we allow them to be refit with the CPAP. And what this does is it prevents the patients who don't really give it a good, honest try and switch out masks a little bit prematurely by compelling them to use the CPAP over a couple of weeks. It gives them a better practical experience with the CPAP mask or interface, and much more likely to use that. Now, in terms of the changes of mask and keeping up on the technology, all of us who have fit CPAP and work with patients, we all have our preference for a particular interface, our go-to mask that seems to seal well and is well received by patients. And so there's a tendency for CPAP, for technicians and therapists to kind of stick with that tried and true mask versus embracing newer technology. So here, to encourage the use of new technology, what we recommend for our staff, when a new mask comes out, we encourage the local rep to come in, give us a little bit of education about the mask, the features and functions that it has. And then we encourage each one of our technicians and therapists to try that mask out with as many patients as they can over the next couple of weeks. We then meet during our monthly meetings to communicate about the advantages and disadvantages that they've seen with the mask, the pros and cons, as well as, again, since we are a DME, we get that long-term feedback of the mask once it's in the patient's home use, how well it holds up. So we seek out that long-term. There's been many a times in which a mask has sealed great in the lab. It's been well received by the patient, but over a long term, it may start to irritate the patient's nose or face, or perhaps the headgear becomes awkward to clean, or straps break and things like that. So that long-term feedback is provided, so it's not just a short term of the mask that fits and seals well during the night. In terms of approaching fitting the mask, and a little typo here, that's not supposed to be the desert cart model, but the dessert cart model. I've seen 3 different approaches to making that first impression with a CPAP mask with a patient. The first one, the dessert cart model, that's when the technician or therapist comes in with a plethora of different masks and offer the patients all their choices and allow them to pick and choose the mask they want. Then there's the tech-directed. So again, the tech has their preferred mask. They present that one to the patient, and if the patient has a problem or difficulty with the mask, then they would switch it out. And I'm also familiar with other sleep centers that have a first-line mask. So across the board, regardless of technician or therapist, everybody starts out with the same mask as a starting point. And if a patient has difficulty or challenges with it, they'll go ahead and switch out that mask at that point in time. So in summary, selecting the right CPAP mask has a lot of potential to increase our patient's comfort, to increase the patient's adherence, to control costs. If we look specifically at studies, studies looking at the different class of masks show that nasal masks and pillow masks are fairly similar in terms of comfort and adherence. Oral nasal masks seem to trend to be less effective with higher pressures required, higher airway resistance, and higher residual AHIs. And finally, embrace technology as it comes out, systematically evaluate the mask so that you can make the best first impression for your patients. Thank you.
Thank you, Mr. Uhles, for that insightful presentation. Now a word from sponsor Fisher & Paykel Healthcare. Fisher & Paykel Healthcare believes that gaining patient confidence is key to successful CPAP therapy, and patient confidence begins with a comfortable mask that fits. Developed from extensive patient-centered research and the recipient of the 2017 Red Dot and IF Design Awards, the F&P Bravita features an innovative air pillow seal for a gentle and comfortable feel. Its adjustable headgear is designed for individualized fit that stays in place for the duration of sleep. To learn more about F&P Bravita, visit fphcare.com/Bravita or contact your local Fisher & Paykel representative. Now I'm happy to introduce Lisa M. Bond, RST RPSGT. She has been in healthcare since the late 1980s and in sleep medicine since the early 1990s, when she discovered that sleep medicine is her calling. She had worked many positions from acquisition tech to lab manager and is currently clinical director and scoring manager for advanced sleep management. Ms. Bond won the AAST 2015 Service Award. As an OSA patient, she also considers herself to be a patient advocate. Welcome, Ms. Bond. We're ready to hear your experience.
Well, thank you so much, and thank you for asking me to talk. And I want to thank Sleep Review for providing this presentation to everyone. We're going to talk more in depth now about the actual mask fitting and helping you to find the right mask for your patients. I have no conflicts, just want to go ahead and put that out there. You're going to consistently hear that the single most important part of compliance is the mask fit, and that's because it's true. That's why you're going to hear it all the time. If the patient doesn't like the mask, they simply will not conform to the treatment and carry through with the therapy. So it's really important that you get the patient comfortable with the mask and that you make sure that it's something that they're going to kind of buy into and want to use. One of the things that was mentioned earlier is that, you know, some technicians have their favorite go-to mask, and that mask may not be the right mask for your patient. So as a technician, it's very important that you are indeed familiar with all of the masks that are coming out, the new masks that come out constantly, like it seems like every other day, and that you talk with your patient to help determine what mask is going to be a good fit for them. I don't like the what you guys was heard about, the dessert cart thing where you bring in a lot of masks all at once. That tends to be a little overwhelming for patients. To us, we don't see anything unusual. Oh, we got all these masks, isn't that great? So patient, that can be a little overwhelming. So it's really something that I would steer you away from is that dessert cart and go more towards talking to your patient and finding out, what you feel would be more comfortable with them. And I think most technicians are very good at getting a feel for if their patient's a mouth breather, if they're claustrophobic, if they don't like to have things in their nose, stuff like that. So I think that's something that we're all very good at and that we really don't need to bring in a bunch of masks all at once. So let's go ahead and talk a bit about fitting the mask. We may fit a mask, especially one we use a lot, with any thoughts about what the steps are that we are doing. But it's really important that you not only understand how to fit the mask well, that your patients learn how to and understand how to fit the mask and what to do for troubleshooting. When we tend to just do things without thinking about what we're doing and the patient doesn't understand. And that can make a big difference in the patient's ability to adapt and continue to function and use that mask going forward. Is the better they understand the troubleshooting and the better they understand the steps that you are doing, the more likely they are to stick with that mask and continue forward with it. So the first and most important thing is to always turn your machine on. Older masks, you didn't need to have that machine on first, but most of the masks now require it to fill with air to make the cushion. And that's something that we do without even thinking. We flip that machine on, but we may forget to tell our patients that they need to turn the CPAP machine on first and before they even put the mask on. I personally like to give the mask to the patient and let the patient just go ahead and hold it up to their own face themselves. You find it kind of intrusive to suddenly just kind of come lunging forward to their face with the mask. I like to let them hold it. I like to let them breathe in and out with it for a few minutes and to see what it feels like. Quick little tip I'd like to point out for you is that some patients, when they're having problems and they feel like they can't breathe with the mask, there's a little trick you can do to get them to adjust to the pressure a little bit. We all have what's called a reserve volume in our lungs, and some people are very sensitive and can feel the CPAP machine changing that reserve volume in order to create that pressure split. Other patients never notice it, but you're going to run into some that do. And an easy way to get past that feeling for them, and because they'll say, I can't breathe, I can't exhale, and especially if you hear them saying, I can't exhale, they're sensitive to that and can feel that, is to simply have them go ahead and take a couple of deep breaths in and out, put the mask on, take a couple more deep, slow breaths in and out, then to breathe in quickly and rapidly for a few breaths, and then go back to some deep breaths, and then go back to breathing normally. What that does is kind of gives their mind a break from the two different feelings of the pressure. And even if you tell them that this is the tip and this is what you're doing and that you're trying to trick their brain a little bit, it still works for a large number of patients that they are then able to suddenly not notice that pressure so much because of the change in the breathing pattern and able to then tolerate it a little bit better. And that's something that they can do even if they come back from the bathroom and they feel like, it feels really weird. Eventually, long-term users won't notice it anymore, but for some new patients, that can be very helpful. For us, we usually go ahead and we know to pull the straps evenly. We put hold the mask, we put the headgear over the top, and then we pull the straps evenly. It's very important you make sure your patients understand that that they need to make sure that they're even with it. And I like to do, as an extreme example, is pull one side really tight and the other side loose, and have the other side real loose, and say, do you see how this mask is now tilting? You don't want that. You want it to be an even pressure, or you're going to feel it's going to get sore on that side. So that's one of the things. Make sure that the patient understands that it's important that they adjust both straps at the same time and that they're even with it. And you want to adjust the bottom straps first and make sure your patients understand that. If the bottom straps are really the more important in some ways than the top straps, because the top straps are there more to help with the stabilization. And they need to understand that if they pull those bottom straps too tight, that they're going to cause that mask to tilt forward. And when it does tilt forward, it's going to create a leak. And that leak's going to go up into their eyes, and it's going to be very uncomfortable. So after you've gotten the bottom straps so that they're on there loose and comfortable, then you want to do the top straps just enough to make it so that it's secure, not moving around too much. This is more for stabilization. And then the last straps that you would do would be any straps that go over the top of the head. And make sure that your patients really, if I'm keep stressing this, make sure your patients understand that that's the order that they should be making adjustments for, and that's the order that they want to tighten or loosen masks themselves. And it's important that they understand that the mask should be resting gently on their face. It should not be tight. A lot of times patients think that if they hold it really tight, that then they will get rid of their leaks. And in actuality, it will become extremely uncomfortable and create more leaks than it'll solve. So we have to make sure that our patients understand it's supposed to just gently rest on your face. This is not life support. So, it's okay if it's gently on your face. That will make it more comfortable and more likely for them to wear it. Again, we don't want to be having any problems, like was mentioned earlier, with it blowing in their eyes. So you want to feel around, see if you can feel any leaks. Just put your hands around it gently and feel the leaks. And a small leak, especially one that's going down towards the bottom, is okay. And you need to make sure your patients understand that the machine can compensate somewhat for a leak. As long as it's not blowing in their eyes, that'll dry their eyes out, and that'll become a problem, and they really will not want to wear it for very long at all. So it's important that they understand a little bit of a leak that's not bothering them is okay. This is not life support, so it's all right, and they don't need to obsess about making sure every tiny leak is gone. That tends to be what causes most patients to over-tighten their masks at home. And we as technicians will do this without thinking and go, yeah, that's fine, but we need to make sure we express it to our patients for when they go home that it's okay. We also need to teach our patients how to adjust for some leaks, because it's not unusual for our patients to have some problems at home, and they need to understand that most leaks can simply be fixed by lifting the mask up, kind of moving it around a little bit, and then setting it gently back down. The mask is not so tight that you can't lift it up because we haven't pulled those straps real tight. So that's usually will fix almost all leaks. And a lot of these leaks happen when the patient rolls over and their pillow's bunched in a certain way, and it kind of knocks the mask a little. So it's very easy for them to fix it that way, and they should know that that's not an uncommon thing, that, they might get a little bit of a leak. And if that bothers you, the first and most important thing to do is to lift the mask, move it, and set it back down. Don't start fussing with the straps at night, because that's going to tend to lead to them wanting to over-tighten it again if they're starting to, play with those straps and doing those as the first line rather than lifting the mask. Once you've got your patient settled and started with that mask, and they're kind of a little bit, over the initial shock of putting it on, I always have patients lay in the bed, and I have them lay on their back, and then I have them roll onto their sides and back and forth for a few minutes. And that's because the mask is going to fit differently, and the headgear is going to fit differently when they're laying down and when they're sitting up. So we want to give them a chance to see how they can lift that mask and adjust it. We want to have a chance to be able to teach them how to lift both straps and adjust the straps together for a good fit without it being so tight that it creates more leaks. So that's a good teaching moment for you with your patients. And then what I also like to do is a little desensitization right before I start the study as well. And with that, I usually put them on like 5 or 7 and 9 centimeters, and I leave them there for a few minutes on each one, and then I drop back down like to 6. And then I'll go in and I'll say, how's the mask feeling? And, make sure that that they understand, have them do any adjustments while watching them and coaching them on how to properly adjust their straps. And the reason I do that is because the mask may be fine at one pressure, but when you get to a higher pressure, now suddenly we've got a lot of leaks. And so having moved it up and then moved it back down, if they can say there for a little while I was laying here and I didn't move and I had some really bad leaks, gives you a chance to work with them on making some slight adjustments so that your mask can handle those higher leaks should they need to have a higher pressure. Your facility should have written instructions to send home. We all know that our patients are very sleep deprived and their memory is not so good. And even if they bring family members with them, they're nervous, and they may forget things. So it's always good to have some written instructions for them to take home with them and, to be able to refer back to and look at. You may have the best DME company in town. You may have a great DME company within your own sleep center, but not every patient has access to that. We have a lot of companies that are drop shipping masks and machines to patients, and so you're really the only education the patient's going to get. And we want to make sure that we give them some written instructions and information about, where to turn to for help, support groups, or if your lab has a DME clinic or anything like that, you want to make sure that they know there are places they can get help for, and if they have questions, they can always call back to the lab and ask you guys, for some help too. When you're doing your titration, sometimes it's handy to use these tools. You may not always have them available to you, but if you do have them, it can help tremendously with that first impression of the mask and the feeling of the CPAP machine. Heated humidity will decrease mouth leaks. Make sure your patients know that if you haven't got a heated humidifier that you're using in your lab, that they do know that when they go home that this will be a huge benefit for them as far as comfort goes and for dealing with things like this, having a stuffy nose, reduces these things. So we want to make sure that they know that heated humidifier is very important and to not skip it when they go home. Way back when, we had no heated humidifiers, and this is something that we have now, so we really do want to try and use them if we can. Also, C-Flex and EPR, these take the breathing wave, and instead of it being a very squared off thing, they make it a more rounded, more of a sine wave, which is a normal breathing pattern. And so if you have that available to you in your lab, go ahead and put it on and use it. There's no reason not to. It is not going to treat anything. It doesn't treat hypopneas or snoring or central apneas or anything like that. It is purely for comfort in making that breathing wave that they have with the machine on more like a normal breathing pattern. So we really want to try and go that route if we can, and we have it available to us to use. People do tend to mouth breathe a lot and to learn behavior. I mean, if you look at babies breathe through their nose, which is why things like RSV are such a problem for children. They don't know how to breathe through their mouth, so that's a learned behavior. When you have obstructive sleep apnea, obviously you're opening your mouth in order to breathe and get the most air in, so that's been reinforced behavior for those patients with obstructive sleep apnea. But you want to make sure that, you take into account that as they get to more towards the optimal pressure, that mouth breathing will be going away. As with heated humidifier, it will also help it to go away. Starting at a pressure that's too low can be problematic for some patients. They can feel air starved in 4 centimeters. You have a lot of patients that do fine with it, but you have other patients that are saying, things like, I can't breathe, I don't feel like I'm getting any air. And this can be a big problem for patients who have deviated septums, or maybe when they were a child, they got their nose broken, or something like that. It wasn't, completely professionally fixed. So that's something that you want to keep in mind, is they may need a higher pressure to feel comfortable. And that might be even 6 or 7, especially if you're using a nasal pillow or something like that, that they may need that pressure. So feel free to try a couple of different pressures on them and find which pressure they feel good at. And don't be afraid to start at a slightly higher pressure. for their comfort if you need to. Simply just document that that's the reason you started at maybe 7 centimeters instead of your lab's protocol of the lower pressure. Also consider the fact that your patient may need bi-level, but you want to make sure in order for that patient to get paid, for them to be able to get that bi-level machine at home, you've got to prove that the CPAP was not tolerated. And one of the ways you can do that is by documenting that you did try a couple of different masks, and that what mask was not the problem. They just simply could not tolerate the CPAP, and they needed the bi-level in order to be more comfortable. Trying, like I said, both higher and lower pressures can also sometimes help, and we talked about that. And, sometimes if a patient's really having a lot of anxiety, you put them on bi-level, they relax a little bit, and once they fall asleep, you can always switch back to CPAP in order to get the titration done and find that proper pressure for them. And slow down a little bit. I see a lot of people that go, every 5 minutes they're increasing the pressure. You need to wait, give that body a chance to adjust to the new pressure. The lungs take time to react, and we want to give them a chance for any events that they have to self-resolve, especially pressure change centrals. So give it a few minutes and let their body self-resolve. You want to remember that your goal is not to bring their AH down to 0. I see this a lot where people are trying to get that down to absolutely no event. An AHI of less than 5 per hour is considered normal, not 0. So we want to make sure that we keep in mind that we're not being overly aggressive and titrating down for that. There is a grading system, as you can see here, on what makes for a good titration. So keep in mind that you may have gotten a great titration even though your patient's not down to 0. On some of the more complicated patients that end up needing to be on ASV and things like that, if you look at the patient, the fact that the patient maybe came in with an index of 60 per hour and you got them down to 10 per hour, that's a successful titration. They are way better than they were before. So a lot of times I see technicians that think that they failed when in reality they did not fail on that titration. They did a great job. They significantly improved the patient, and the patient is doing much better than when they first came in. And so, that's another thing to keep in mind. Plus, if that pressure is too much, the patient's going to have a hard time adjusting. So besides the thing with the mask, let's make sure that we don't over-titrate and give our patients way too much pressure. So let's see, that pretty much wraps up what I have for you guys today. And feel free at any time, you can give me some questions if you want. We also have at the ASP some stuff for technical guidelines that might help. And, of course, you can, like I said, ask questions at the end of the presentation or send us an email and we'll be happy to answer.
Thank you, Ms. Bond, for the wealth of practical information. Now a word from sponsor Philips Respironics. You're devoting more resources to getting patients adherence sooner, but is outdated mask technology making it more of a struggle? Open your eyes to Philips DreamWear, a radical departure from traditional mask technology that was designed from scratch to keep patients engaged from day one. I'm now pleased to introduce Russell E. Rosensky, RRTSDS, RPSGT, CPFT, MS. Stony Brook Professor Rosensky started his career as an RT at John T. Mather Memorial Hospital in Port Jefferson, New York. He later trained in polysomnographic technology and opened the sleep lab at the hospital, where he was later promoted to supervisor. He joined the respiratory care program at Stony Brook in 2001 as adjunct faculty, and in 2005 he accepted a full-time faculty position. He has served as program director for the polysomnographic technology program since 2009 and recently converted it from a non-credit certificate to a bachelor's degree program. Welcome, Professor Rosensky. We're ready to learn from your expertise.
Thank you. I'd like to say thank you very much for giving me the opportunity to talk today and to thank Sleep Review for putting together this webinar. I have no conflicts of interest. One of the things I found historically clinically significant when fitting patients is to actually go over a brief review of the patient history, to go over their height, their weight, their BMI, and get an overall view of how good or bad that their probable sleep-disordered breathing is going to be. You could also look in the physician's notes as far as the evaluation of the upper airway, the Mallampati score as far as from 1 to 4 to talk about how open or closed the airway is, if there is a high arch palate, also to see if there's any nasal or oral abnormalities, a deviated septum, polyps, if they suffer from postnasal drip, chronic sinus infections, etc. If they have a recessed jaw, retrognathia, or if they have an enlarged tongue or a scalloped tongue. So all of these things will help to talk about probable severity of the OSA, because this way you could start to see what type of mask would probably fit down the road. Reviewing of the original sleep study in its entirety is important to go over the severity of the sleep-disordered breathing, not only the apnea-hypopnea index, but what type of events. Were they primarily obstructive, combination of mixed centrals? You want to look at the average duration of the events plus the level of the desaturations. I find that patients, when they pass a certain length of time on their apneas, that past 60 seconds, the AHI actually artificially deflates. So I have had patients clinically that have had apneas that last 2 to 3 minutes, but when you look at their AHI is down 15, 20, 22 events per hour, which is in the moderate range, but in reality their event duration was so long that clinically they're actually very severe. If you want to find out if it's going to be where they had a full night titration, a full night titration gives you a better view of how long they were on different CPAP pressures, what stage of sleep they were in during that time frame, how long they were on it, what body position they were in. Clinically, you find that most patients have most of their obstructive events while laying in the supine position. Specifically during REM sleep, you'll see longer events, more severe desaturations. You might pick up more cardiac abnormalities. And those type of events are relevant when you want to try to properly fit a patient, because the goal is to try to treat them so that they would breathe with an AHI less than 5 per hour, but you also want to make sure that they're going to be comfortable. Historically, split night studies don't have the high efficacy long-term usage of the PAP device, and I think that's more clinically due to the fact that the patient slept 2 to 2.5 hours without the device, then they were titrated, and then they only slept clinically at therapeutic levels for maybe 2 or 3 hours. You want to discuss with the patient as far as the history, again with the polyps and sinusitis. You want to also observe the patient when you're discussing this. There are patients I've seen that had severe nasal obstructions that, as I'm just discussing possible treatment modalities, explaining to them how CPAP works, that all they were doing was actually breathing through their mouth. It is a learned behavior, as Lisa discussed before, and part of my questioning would be then to pull out that information that they might have not discussed with the physician. It might not be in their chart, so you want to assess that by direct observations. You also want to look for facial hair, other types of restriction that may impede various types of masks, whether it's a nasal or full face or nasal pillows. A proper titration is important for compliance of patients. If you over-titrate, you can cause central apneas, as clinically we all know. But part of the other problem is that if they over-titrate, they'll start to fragment their sleep, possibly. And in fragmentation of the sleep, the patient then physically feels that they did not, quote, rest well. Lisa discussed that you want to do a kind of take your time titration to make sure that the lungs and the patient has time to acclimate. That is true. And you also want to try to get it where the person has a good amount of hours, 4 or more hours at a therapeutic PAP pressure. At a therapeutic PAP pressure with 4 or more hours of sleep, the patient should wake up feeling that they slept longer, they slept better. Hopefully they would have REM rebound, slow wave sleep rebound. Thus they would feel more rested and overall, quote, better. And I've had patients, we probably all have had this at one time or another, where they wake up after a night titration, they just tell you they slept beautifully, I've never slept so well. That is a strong indication. If you were able to get them on the PAP therapy quickly at home, that most likely they're going to continue using that therapy. Addressing leaks either around the nasal part or around the mouth, because they do end up being mouth breathers, is important. Leaks can lead to increasing the PAP pressure higher than what is actually therapeutically needed. And patients will complain of having a dry mouth. most labs and most patients at home use now heated humidifiers. The heated humidifiers will help for the dryness if a person is a mouth breather, but the goal is to try to go in and reassess and either use a full face mask or a chin strap to try to keep the patient's mouth closed during the titration. Patients need to be educated about long-term consequences of untreated obstructive sleep apnea or other sleep-disordered breathings if they fail to comply with the PAP therapy. A lot of patients in my past experience have asked about, they know about cardiac disease, they know about hypertension, they know about AFib, A-flutter, other cardiac abnormalities. But if you ask them about sleep, they really don't understand the long-term consequences, physically, psychologically, behaviorally. So they don't take it as truly serious as other individuals who have other types of disorders would. So properly explaining what types of long-term consequences, such as the hypertension, the increased risk for heart attack, strokes, correlation of atrial fibrillation with sleep-disordered breathing, diabetes, weight gain, and then, of course, work-related issues. I'm in New York. The MTA here is now trying to screen a lot of their employees for sleep-disordered breathing because they realize that these are individuals that are operating vehicles, trains, buses, etc., and that poses a risk for not just the individual, but the overall community as well. Acclimating to PAP therapy, desensitization is important. One of the things I have instructed patients to do for a long time was actually having the patient utilize and remove the device while watching TV during the day. A lot of patients in the evening come home from work, they'll watch TV, so I ask them to take the mask and get very familiar with putting the mask on and off. When a commercial comes on, take the mask, put it on, have the unit running so that he'd start to breathe, feel the pressure, feel what it feels like to go through the nose, through the mouth, adjust the mask, learn how to adjust it themselves because we're not going to be there to fit them again. We might fit them in the lab, but they need to really be able to implement and discontinue the device on a regular basis with minimal problems. Okay, so various various interface options, nasal pillows, nasal masks, full face masks, gels, cushions, are all there to help make sure that the patient will be very compliant with the therapy. The goal is to make sure that they will use it on a nightly basis for at least 4 hours a night, 70% at a time. Other factors that can help, humidifiers. We are meant to be nasal breathers. The nose does three things: filters air, warms air, humidifies air. And when we use a CPAP or a PAP device, it's going to blow in extra air. So we want to make sure that that air is filtered. It is going to be very warm and humidified, decreases the nasal congestion, decreases dryness, decreases the likelihood of nasal bleeds. It feels more natural. Ramp features or expiratory pressure relief valves, those are helpful for getting a patient to get acclimated to the types of pressure. There are times where I tell patients, even though they have the CPAP or PAP unit at home, to come back into the clinical setting and demonstrate, put on the mask, start the device. I would like to see how you use it in the facility because this is how they're doing it at home. And one of the problems is doing that demo of a PAP nap in the clinical setting shows me whether or not they're utilizing the device correctly or not. Feedback from the clinicians, from the doctor, home care company, tracking their compliancy reports is important, and feeding that all back to the patient, having the patient learn how good or bad they're using the device or utilizing it is extremely important. Patients will think they use the device all night long, and meanwhile, somewhere between 2 or 3 in the morning, they woke up, half awake, pulled the mask off, went back to sleep, and the machine was running for 2-3 hours. Then they wake up, realize, oh, the device is off, they put it back on. They'll report to the clinicians that, oh, it came off in the middle of the night for 5 or 10 minutes. The compliancy report shows that that is not true, and feeding back to the patient to tell them that they got to try to work on it and working with them is extremely important. Other ways to improve compliance, instead of just using regular CPAP, you can use bilevel, C-Flax, AutoPAP, the expiratory pressure relief valve. These are ways to make it a little bit more comfortable, but I recommend that patients try to use CPAP or C-Flex first, and then from there, if it's needed, that other devices can be implemented. You can do combination therapy. Somebody who is really severe, somebody who has a lot of problems, especially sinus issues, they might need corrective surgery. A patient who has very severe Sleep disordered breathing while in the supine position. They can't tolerate the high PAP pressures. Maybe a combination therapy of a positional device in conjunction with CPAP at a lower pressure to make sure that they will use the device on a regular basis can be beneficial for them. Routine follow-up, and the follow-up has to be done with the sleep lab clinicians, the home care company, and the physician all as a group package, following the patient to find out if there's any problems, let them know as soon as possible so that the lab can work out issues, whether it's mask fitting, different type of mask, different pressure. Maybe it's a little bit hard. Maybe they want to adjust a ramp feature for a longer feature. Okay. Educating patients about proper sleep hygiene will actually help improve compliance because patients, unfortunately, are like most people, they will actually sit there and will lay in bed, watch TV, read, eat things, do other things, and not realizing that is poor sleep hygiene. And unfortunately, a lot of patients fall asleep that way. Then they wake up, oh, let me put my mask back on, I'm going to go to bed now. And that decreases the efficacy of the device because they're not using it the recommended time on a regular basis. Eating the proper foods that promote sleep or avoiding foods that rob you of sleep, caffeine, alcohol. Caffeine being a stimulant can fragment. Alcohol in the beginning of the night, depressant, latter half of the night starts to act as a stimulant. Consuming alcohol can make patients, arouse more frequently, have limb movements, frequent bathroom trips. So this can decrease the level of compliancy long term. Okay. You also want to ensure that the environment that the patient is going to be using the device in their home setting is properly set up. Dark room, proper temperature, keep the distractions down to a minimum amount. Of course, that performs into the sleep hygiene, no reading, eating in bed, watching TV, etc. You want to make sure that the patient primarily is going to bed with the PAP device on when they're going to go to sleep. Big terminology difference, you have compliance and effectiveness. A patient can be compliant according to the insurance guidelines that most of us go by. For Medicare, they use it for at least 4 hours a night, 70% of the night for 30 consecutive days. The part is you actually want to be effective. You want to reduce or get resolution of the patient's chief complaints, their signs and symptoms, their daytime sleepiness, the morning fatigue, morning headaches, naps during the day, headaches, etc. So the goal is to get rid of those issues, and that will increase the compliance. Because if I am not using a PAP device effectively, the problem with it is, as far as I am concerned, I am not getting therapeutic benefit out of it. I am not going to use it. So being effective will help ensure long-term compliance. So now compliance, various studies show differences in the compliances. Okay, varying rates between 20 to 50% failing to comply, and typically patients will discontinue therapy within the first 4 weeks of usage. And this is because it's something new. A lot of patients don't like to have new things in their life, especially something that they think is, quote, complicated. A PAP device, something they have to clean, they have to take apart every morning, they have to let it dry, they have to get water, they have to assemble it, put it on. It's something that is not quick and easy. Unfortunately, a lot of people like quick and easy items. Give me a pill, give me a shot. This is something that they have to be trained. Behavior modification has to be brought in to get the person to use the device on a daily basis. Okay. Now failures, the initial night of a PAP titration is usually the best indicator. Patients with a low AHI or overall low respiratory disturbance index where they really don't have a lot of fragmentation of sleep, you're dealing with an index between 5 and 15 that tend to be very mildly symptomatic, some snoring, the bed partner's complaining. I found clinically that they are harder to deal with long-term compliance than somebody who had severe obstructive apnea, where the person who had severe obstructive sleep apnea, they literally feel a night and day difference between the device. And I've had patients who have actually traveled, and one gentleman actually went to Europe, and he forgot his PAP device, and he was ready to turn around and come home because he knew he would not sleep well without his PAP device, and he relied on it every single day of his life because it made that much of an impact on him. He was also a very severe patient. So, timely setup of the equipment between the home care provider with the patient is also important. I know with the insurance regulations and going through insurance clearances, not every sleep lab also is a dispenser of the DME equipment, but trying to get things done in a timely fashion is important. If the time lag between the initial PAP titration in the facility to where the patient is set up at home, if it's going to be 2, 3, 4 months, the patient might not remember on how good their sleep was, and they might find it more of an inconvenience. phone call follow-ups for the first 2 or 3 nights of using of the device with the downloads, if you could get those on the internet through the cloud, so you can see whether the person is using it, what time they're using it, check about their records, see if it correlates to when they say they go to bed, and how the device is responding. Certain reports now will actually give you the apnea-hypopnea index on the device, and just to get a feedback of how good or bad they're doing. If they're doing bad, call up, find out, maybe even bring them back in for a follow-up appointment. If they're doing well, give them a call up and tell them that they're doing well, answer any questions they might have, see how they're tolerating it. Improving compliance is multifaceted, and it needs to be customized for each individual patient to suit that specific patient's needs. Not all patients tolerate PAP. A lot of people think that, my background in respiratory therapy and polysomnography, I'm going to be pushing PAP. I know PAP is not for everybody. So you have to be open-minded and keep in mind that there are alternate therapies out there. There are combination therapies. So variable alternatives should be available to ensure treatment for the patient, and the goal is to ultimately treat the patient to make sure that their disease or disorder is improved or eliminated.
Thank you, Professor Rosensky, for sharing that real-world perspective. Audience, we are about to start the Q&A portion of the webinar, so this is a good time to write up your Q&A questions if you have not yet submitted them. But first, a word from sponsor ResMed. At ResMed, we understand that every face is unique. Using proven and trusted cushion technologies and innovations, the 20 series masks reduce the guesswork for lab professionals like you. The AirFit 20 series with Infinity Seal cushion was designed to fit a wide range of patients regardless of facial profile. ResMed's new AirTouch F20 is its first mask to use a memory foam cushion that conforms to each face. It was designed to reduce red marks and provide a great seal for patients, even those with facial hair. ResMed will be in touch with details on how you can get an AirTouch F20 and feel the comfort for yourself. If you're enjoying today's webinar, subscribe to email notifications about future events at www.sleepreviewmag.com/subscribe, where you can also sign up for a free print magazine subscription. Now, let us take our first audience question. Professor Rosensky, this came in during your talk. Do you need a prior authorization for a PAP nap?
In New York, they allow PAP naps. You can, depending on the insurance, it can have to be authorized. Some insurance companies don't require authorization. It depends on specific insurance, but there is a code out there for PAP naps.
Thank you. Mr. Uhles, this came in during your presentation. Do insurers still replace masks for DME if patient is not able to tolerate in the first 30 days?
So according to my understanding, the insurer companies do not replace the CPAP mask. They'll provide one interface every 6 months, depending on the insurance, obviously. Oftentimes, the mask being switched out or allowed to the patient to have different options falls on the DME that's setting them up. So that goes to their bottom line. If they're going to present a couple of different interfaces to the patient, allow them to try them, that will go against their cost.
Thanks. And I'm going to send this one to you as well. In your research, did you find that patients switching to the switching masks end up going back to the original mask that they chose? Any research or any personal experience with that?
Yes, I think that's a great question. I did not come across any particular research studies or citations looking at that. However, that is something that we have observed here within our lab, and as I mentioned during my presentation, the primary reason why if a patient comes, gets refit, started on a second mask, we encourage them to hold on to that first mask, even if they want to return it during the initial 30-day trial, because we find it's about 50-50 in which at the end of the 30 days, using the two different masks, they may decide to go with the first mask. A lot of times we like to have choices, and having those two choices presented to the patient, they decide that their first option was actually the better.
Thanks. Whoops, Professor Rosinski. I'm trying to push this one out so everyone can read it. Professor Rosinski, this person says, I am an RT that works for a home care company. Any tips for fitting masks for clients when they are sitting through the appointment versus lying down?
I always like to start fitting a patient while sitting up in bed, so this way they are more comfortable. Get them to where they can take apart the mask, adjust the gear so they understand what I'm doing. Then I would put it on their face. I would fit them to explain how it is going through, and then I would take it off and then ask them to try to fit themselves. This way they start right from the get-go at the time of the titration to understand how the device is actually placed on themselves and how they could remove it. I also explain in case there's an emergency, if they get too much air aphasia, air swallowing, and they feel nauseous, on how they could quickly remove the device. I then will have them actually lie down and breathe normally through either their nose, if it's a nasal mask, or a full face mask through their nose or mouth. And I want them to be comfortable breathing normally. So I prefer to start them sitting up.
Thank you. Mr. Uhles, what is being done to deal with the impact on bed partners from a patient starting PAP therapy? Lots of patients are concerned about noise, and we see patients at our clinic whose partners are being disturbed by the air put out from the exhaust ports.
So that's interesting. That's a two-way street. Not only is it important for the patient use of CPAP not to interfere with the bed partner's sleep, but studies have showed that if a bed partner is not supportive of the patient wearing CPAP, that the patient's adherence is much lower. So obviously, over the last couple of years, well, over the last decade or so, CPAP machines themselves have become progressively quieter to the point where they're almost silent. And one of the big complaints that bed partners have is the bias flow of the CPAP mask or interface when the patient exhales, either the sound or the air blowing out and being directed right across them. So many of our last generation CPAP interfaces really have worked a lot to diffuse this bias flow, to direct it away from patients, or to decrease the sound involved with that.
Excellent. And Mr. Uhles, I'll put this one to you first. How do you feel about patients trying new masks and then switching between two masks to prevent pressure sores or irritations from using the same mask every night?
What we have observed is over the years, let me take a step back. First off, we should be able to find a mask that fits the patient comfortably and well and shouldn't cause any long-term abrasions or discomfort or anything like that. We have found over the years that sometimes nasal pillows, due to the pressure required to seal at the end of the nose, sometimes can cause a little bit of irritation when a patient wears that long-term. Within the limitations of the patient being provided with interfaces either out of pocket or to the patient's insurance companies, we will at times encourage those patients to have a different style of an interface as a backup. And that way, if they start to experience any irritation from using a particular style of mask or interface long-term, they can switch that back and forth. But again, if we get a good interface that seals well in the first place without having, and the patient's instructed not to over-tighten the headgear and the straps, it shouldn't cause long-term irritation to the patient in the first place.
Yes. Professor Rosinski, do you have any experiences with that, a patient wanting to switch between two different masks?
Yes, I have. I found that research is both a blessing and a curse, because I've had patients come in and tell me that they have a friend from work or a family member and they use this mask and this is what they love and that's what they want to use. Meanwhile, the patient doesn't understand that their profile, I can't really get a nice good seal if you have this big bushy mustache and a full beard going on with a full face mask, even though you have somebody else using the same type of mask at home. So it is a blessing and a curse. I have switched masks with patients in the lab setting where patients will try something for an hour or two and they wake up, they tell me they can't breathe, they'd like to try something different. And in the home care setting, they have also changed. So it does happen occasionally, but that's where I say that the internet and researching masks can be both a positive and a negative.
Great. Let me push this one. And Professor Rosinski, I'll put this to you as well. If a patient is requiring low pressure for CPAP, should pressure relief be used?
You've run into a slight problem because the goal of having the CPAP at a minimum of 4 is you want to blow off the end-tidal CO2 and moisture that can build up within the mask or the interface. If they were on a CPAP of 8, I could say yes, you could use an expiratory pressure relief. That's fine. On the 5, I'm not sure if you're going to really get much of a benefit out of it.
Thank you. Let's see. Professor Rosinski, I think you alluded to this earlier. Do you have any tips for fitting a full face mask for a client with a beard? I was told by a sleep tech that the client should be fitted with a nasal mask if they have a beard, ?
Fitting somebody with a beard is extremely difficult. There are different types of masks. There are the ones that have the foam inserts. You have the gel cushions. There are different actual components that will kind of really try to seal between the mask going around the hair, through the hair type of. As far as dealing with a beard, it is a trial and error. It is a problem. Again, this goes back to the severity of the patient. If they're not too severe, I'd probably try to lean more towards a nasal mask because of the problem sealing with a full face on a beard.
Let me see. Okay. Mr. Uhles, I'll send this to you. Are there any suggestions for improving compliance with elderly patients who say they don't need it and they've lived their lives, quote, sleeping fine?
Yeah, I really liked Russ's approach during his presentation that, the initial step is really to review the patient's history, their severity, and I think that's where you start is education of the patient. So many times if a patient, regardless of age, does not want to wear their CPAP, that's our starting point. We begin with them, what is obstructive sleep apnea, the consequences of it. We make it very specific to them. You indeed have sleep apnea. Here's the severity of your sleep apnea and how that may be interconnected to your health conditions, and this is how we're gonna approach it and deal with it. And again, I liked Rose's approach that CPAP isn't the only option out there. It's one of our best, especially if we're looking at patients with severe sleep apnea. But if we have that patient that's really resistant to wearing CPAP, we need to look at the alternative therapies for treating sleep apnea as well. But my first and foremost approach would be to educate the patient, make sure they understand the consequences of untreated sleep apnea and how that relates specifically to their own health and experiences.
Thank you. Professor Rosinski, when the patient's final mask is a full face due to mouth breathing, but then the DME puts them on a nasal mask, is the pressure altered, and how is this patient then followed?
That becomes quite complex. What concerns me is if they were titrated in a lab and it's been ordered as a full face, but then the DME puts them on a nasal mask, I would check to make sure, one, the prescription is being followed. If it just says, CPAP at 8 and then the DME ended up putting them on a nasal mask, it can become a problem. Can the pressure have to be altered? It might, and that's where downloading the compliance, either for the first few days or the first week at most, and then looking at that data to see if it is resulting with a bad leak, look at what the leak is, what the AHI is, and then might have to adjust the pressure accordingly. And then the patient would need to be followed a little bit more frequently than somebody who is getting the full face when they were ordered a full face.
Excellent. Well, in order to finish on time today, I want to conclude by saying thank you to our 3 presenters and to our audience members. Today's webinar is being recorded, so you may re-watch for free anytime using the same link you used to log on today. Feel free to share the link with colleagues who may have missed today's live event. Email me at sroy@medcore.com with comments, questions, and future webinar suggestions. And visit us at www.sleepreviewmag.com. Thank you for participating in the Sleep Review webinar.